Well, good evening. I'd like to go ahead and get the program started this evening. If I could have your attention, please. I wanted to remind everyone that after the presentation this evening, there is going to be a birthday celebration in the main room and a birthday cake served. And we'll sing happy birthday, I guess, if it's agreeable with everybody, to Dr. David Williams and Dr. Brewer Cover. So they have birthdays on the same day. Well, tonight we're very honored to have a very distinguished speaker, a very important person. He's Chief of Space Medicine at Johnson Space Center, Dr. J.D. Polk, and he actually cut short his visit, which was in Ohio today, to come back and be with us, and I really appreciate that. And I think you'll enjoy what he has to say about the space medicine.
Well, if we can go ahead and put the slides up on the board there. I don't see them come up yet. There we go. Well, my mother told me never to stand between anyone and the bar, so this is going to be a brief lecture. And I heed my mother's advice very often. And also, Charlie Bolden and I have an agreement that since he's not confirmed yet as the NASA administrator, anything I say tonight does not require a letter of apology to him tomorrow. So on that note, what I want to talk about, the slide said past, present, and future issues, but what I really wanted to talk about was how you strategically plan for space missions, and especially exploration missions. And you'll find that this lecture gets rehashed multiple times. I've been asked to talk about this lecture multiple times because folks do a really good job of understanding space physiology, very good job. But sometimes the nuances of strategic planning for a space mission and the logistics that go behind that are kind of lost on folks. And so that's kind of what I want to talk about. And probably the reason I'm the chief of space medicine is I'm the only flight surgeon that knows how to do a budget. So between budget and strategic planning, it's been a positive career move for me. Obviously, where do you start? The first thing that you have to do is pay attention to history. And we had to bring folks back because you lose corporate knowledge. We had to bring the Apollo folks back. We brought the Skylab folks back. And what's interesting is, you always have the written documentation of the after action. And then you hear what really happened. Because, there's always the political correct document that people wanted to make sure that, it was going to be presented in an open forum. They wanted to say the right things. But it's amazing after, so many years, how much detail the guys remember and how much, why certain things, why certain bolts were where they were, etc. And it was actually extremely valuable for us planning for constellation and exploration missions to talk to the folks that had already been there and done that. Then you have to look at where you are now, the current operations. And that includes budget. And sometimes we have very high hopes and aspirations, and whether we like it or not, every 4 years we get those reevaluated with a new administration. And also have a budget that kind of curtails our plans every now and then. You also have to define the concept of ops. You have to know what you're going to do when you get there. It's one thing to go to Mars or the Moon, but what are you going to do when you get there? Because that really changes how you're going to plan for the medical treatment or what things you're going to do. If somebody's going to be rappelling off of some mountain somewhere or driving a rover down in some ravine, suddenly thoughts of trauma spur into my head. And of course, I'm an ER and trauma doc, so that's why they always come into my head. But you have to know what the ConOps is going to be. You also have to define the levels of care. We're going to talk about that a little bit more. And then the 6 tenets, or tenets, depending on how you pronounce it. I always like tenets. It sounds more European, like I'm more educated. And the 6 tenets are mass, power, volume, time, money, and risk. And very often my colleagues from medicine forget those 6 things, that those six things actually judge what I fly. Because folks will say, aren't you going to fly an MRI to the moon? And I'm like, let's see, mass, power, volume, time, and money. No. Right now, I'm lucky to get food, water, and clothing, and a small medical kit on board. And so folks don't very often understand the constraints that you're under when you're planning some of these missions. Well, the 6 tenets we've already talked about, but the astronauts in the audience already know that it takes 27 pounds of fuel for every pound that I fly. 27 pounds, and you can't get that at Exxon or Shell. That's kind of interesting fuel, and it's very expensive. So it costs me about $20,000 per pound currently to get to low Earth orbit. It'll cost me even more than that to get to lunar orbit. It'll cost me even more to get something off the moon back to Earth. And so you have to be a little picky when it costs that much to fly a pound of material as to what pound you're going to fly, and start being selective and triage what those things are going to be. And Polk's law is that you can increase at least 2 of those things, but you better decrease 1, and that 1 is risk. So the past, obviously we didn't have a lot of experience. We didn't know were your eyeballs going to bulge out, were you going to be able to see when you got to orbit. We had consensus panels from the Air Force in the 1950s. We didn't know what was going to happen. We didn't share a lot with other countries and vice versa. We didn't share much with our Russian colleagues. Our Russian colleagues had some things that they learned that we didn't share with them, or they didn't share with us. We weren't exactly explaining things to each other as a country at that time, or as international partners. We were rivals, and so we didn't learn from each other's lessons either. We selected from a very specific group of individuals, fighter pilots, typically Korean War veterans at that time. The flights were relatively short. Current operations. The astronaut makeup has pretty much changed. We don't select just the hardened fighter pilot. The average age back in Apollo was 36 years old. The average age now is 46. And Sylvia, the lady who checked me in today, said, "Wow, you don't look young enough. You don't look old enough to be the chief of space medicine." And I reminded Sylvia that it's not the years, it's the mileage. And I've got a lot of miles. The missions are longer. And in fact, from a physiologic standpoint, strictly speaking from a physician standpoint, the physiology is much different on a long-duration mission than it is on a short-duration mission. They're actually 2 different animals when we talk about them. There's multinational sharing and learning. We have an international panel that, I was telling Filippo at dinner, I think nothing of coming in and talking to Kaz and Filippo and Ulrich and seeing Dr. Bogomolov and Dr. Morgun. And that relationship we've taken for granted because it's become a very close-knit relationship where we work internationally as partners a great deal. But that was something very foreign back in Apollo. The medical kits, the equipment, the exercise hardware, all from multiple nations. Now, this slide is both humorous but also very true. I'll let you read it for a second. It took a lot of trust for us to convert to International Space Station operations. I mean, we came from different cultures, we came from different languages, different backgrounds, and I bet the first MMOP meeting and first MSMB meeting where we had multilateral agreements was probably not as friendly as some of the last ones were. And so it takes a great deal of trust when you have an international program and you're going anywhere, whether it's to the moon or even going around an Earth orbit. Preventive medicine is 90% of what we do. What I always tell the flight directors when they're new flight directors, and I have a class that I give to new flight directors, is you shouldn't hear the surgeon say anything. The surgeon should be in the back corner, and if he's done his job well, he should not say a word during the mission, because 90% of what we do is before the mission. Most folks think that the astronauts are extremely healthy folks, and they are. We select extremely healthy folks. But something happens after you're age 40, or at least it happened to me after I was age 40. Things start breaking and falling off, and you have to go fix stuff. And we do fix a lot of stuff. We fix a lot of things on the astronaut corps because it is in our best interest to do so. Now, I had folks from Congress say to me, well, if somebody's got AFib, why don't you just kick them out and get a new astronaut? Well, I spent $7 million training that individual over the last 8 years. So it is actually financially better for me to go spend the 20 grand to go get the AFib ablated and fly that person than to retrain somebody else to the tune of $7 million. So even though there is a altruistic self as a physician of wanting to heal and get people put back into their position as astronauts, there's also a fiscal reason to do that as well, which fortunately accountants and NASA administrators and folks actually understand a little bit more than the altruistic part. We have a couple of things that we do. We have primary standards, our selection standards, which are very tough. If you've had a kidney stone and you apply to the astronaut corps, you need not apply. But If we spent $6 million training you and you have a kidney stone, we're not kicking you out, we're keeping you. So we have secondary fitness for duty and medical standards. Those are fairly stringent, and it's amazing what you find. It's interesting because we're the only ones who look for things that typically your family doctor won't look for. You take the typical person in their 40s who doesn't have a headache, doesn't have any neurologic symptoms. Their family doctor doesn't just go get a random MRI on their head. And so very often they don't find the things that we find. We are going to go get MRIs on the brain on folks that are in the International Space Station program. Have we found things? Yes. Pituitary adenomas and other things that we have gone and then fixed and then flown those individuals. Things that would have caused significant sequela had they gone to orbit and that tumor had pressed against the optic chiasm. So it was both, life and limb saving in many ways when we do some of these tests. Tertiary care, obviously, when you do risk, you have the selection standards to rule out certain things. You have the secondary fitness for duty standards that we do, and then the remaining risk is what you're treating on orbit, and that's the tertiary care. That's why we have the medical packs, the ultrasound, those things on orbit. Preventive medicine has become an offensive thing for us, and what I mean by that is your family doctor, if you go see your family doctor right now, might treat your cholesterol at 200, might treat it at 220, might treat it at 180, might treat it if your LDL is over 100. You're not really sure where your family doctors might treat it. And if you see Dr. Myers on Monday and Dr. Smith on Tuesday, you might get different treatment. Well, we have taken preventive medicine to a very offensive level and trying to reduce the risk in the astronaut corps. We probably have astronauts on statins much faster than your family doctor would have them on. We treat things like PSA, for example, your prostate-specific antigen. Most people treat it when it gets to a level of 4. We actually treat it based on a level of rise, whether it's risen at a particular rate over a year. And most people would say, well, that's very aggressive, doctor. I'm not sure if you need to do that. But we've picked up 3 prostate carcinomas by doing that. And we've saved 3 individuals, the sequela and potentially the mortality of prostate cancer because of that. Now, 5 main initiatives that we've had at NASA, quality, consistency, patient information, data flow, OC health surveillance, and focused operational research and development. And I'll talk about some of those a little bit, but I promise not to stand in the way of the bar too long. Quality. Most people don't really know what quality is in medicine. We have quality of service. They give you a survey and you say, well, the parking lot was nice and the nurses were nice and the floor was clean. Quality of care, however, most people don't say, well, my doctor treated me according to the American Heart Association guidelines and put me in the top 1% of a risk category. Most patients don't know that. They don't know the background to judge quality. Consistency is another thing. We had the Bachman report say we needed to be more consistent in our care. And that is true. You do need consistency. But you can see somebody who is consistently bad and get really good consistent care. And you can consistently see them and get consistently bad care. Consistency and quality is not the same thing. And so we had to figure out ways to tackle those problems. Patient information data flow, 50% of our care right now for the astronauts assigned to ISS is not in the United States. 50% of the time they're in Russia or training in other countries. And so we needed to make sure that when somebody was in Russia or in other countries, that the physician or the flight surgeon treating them knew what their allergies or their medications were and had the same type care at their disposal as the ones in Houston. It's both the patient safety aspect as well as quality aspect. Occupational health surveillance. Despite the fact that we've flown in space for 40 years, OSHA tells me what to do on an astronaut if they get exposed to cadmium or radiation or lasers or other things. But on orbit, we never came up with any particular protocols for that. And so we are starting that now to where we do occupational health surveillance based on exposures, whether that's lasers, whether that's radiation, to make sure that those exposures do not cause a particular disease down the road. Now, we used to have the program called Longitudinal Study of Astronaut Health, and it was a study. Essentially, it was a study of the astronaut throughout their lifetime. And at the end of their lifetime, we would look back and say, yep, they were more at risk of X. That really doesn't help the patient very much, to stand over them and say, yep, you were more at risk for renal cell carcinoma. Thanks for participating. We wanted to change that, and we've changed that into lifetime surveillance of astronaut health. That particular program will actually change and morph over the next 2 years to where we're actually doing preventive medicine based on age-based protocols, so that when you turn 50, you're going to get your colonoscopy, your ultrasound, some of those tests to prevent you from getting those diseases that we know that you're at risk for because you flew in space. It's turning the paradigm 180 degrees. So the reason for that is to reduce errors and to increase quality. Medical errors right now in the United States account for 44,000 to 98,000 annual deaths. That's an awful lot in the United States. That's a lot of people that die due to medical errors. And we're trying to make sure that we get more consistent, that we give high quality care, that we look for things throughout their lifetime to prevent something that's very preventable. And we're doing that through Lean Six Sigma processes. Now, up until about a year ago, the flight surgeons thought Six Sigma was a fraternity, but it's not a fraternity. Lean Six Sigma is essentially borrowed from industry. It's the reason a Toyota Camry rolls off the line and only has 3.2 defects per million. Unfortunately, in the United States, you have about 1 in 100,000 for errors in the medical realm. That's not a very good statistics. Not only is that not Six Sigma, that's not even 3 Sigma, that's not even 2 Sigma. And so we're trying to get some of those things brought into our care in the astronaut clinic. I'll give you an example. The flight surgeons right now, I've got 16 different flight surgeons, and they were treating things 16 different ways. So we started to standardize in evidence-based medicine and started to develop clinical practice guidelines that said, yea, verily, if somebody has a cholesterol of blank or an LDL of blank, the minimum that you're going to do is this. And then, you can still have your own autonomy as a physician, but the minimum thing that you're going to do is blank. What we found was that the astronauts were actually placed on statins much sooner than they were if we left them to their own devices, or the physicians to their own devices. What that also showed was that we were decreasing soft plaque due to cholesterol and other risk factors. So the goal is that we'll have very long and old astronauts, long in the tooth and very healthy old astronauts who are not dying of coronary disease. But there's a secondary gain to that, and I'll go over that in a second. The other thing that we did was standardize the electronic medical record usage so that we had it so you could access it from Russia, Kazakhstan. If I needed to write a note on a patient from a coffee bar in the middle of Kazakhstan, I could do so. And that helped greatly because then the guys all knew what was going on with the patient. If somebody got treated for something in Russia or Kazakhstan or in Europe or in Canada, I knew it in the clinic, and then I could follow it up in the clinic as well. So how do these things help spaceflight? You got to remember the 6 tenets. And I'll tell you right now, this is where Lipitor comes into play. An AED, like the one that's out in the hallway out here, costs about $5,000. You can buy the AED on the market with a prescription from a physician and hang it on your wall. However, to fly it in space flight, remember, 27 pounds for every pound I fly. Let's say that AED is 10 pounds. Plus I got to burn it, mutilate it, off-gas it. For some reason, they always charge me acoustic analysis too. I don't think anybody's ever gone deaf from using an AED, but the engineers always charge me that anyway. By the time we're done with flight certification, that's a $5 million AED. In fact, that's what it cost us to fly it. By the time you train the crew to use it and you put upkeep and replacement costs, you've now got a $10 million AED. If I can reduce coronary disease by standardizing my care and making sure that I have a less than 1% risk of coronary disease that I'm flying, I don't need to fly an AED. So I just saved the space program $10 million. And Charlie, I'd like that in my paycheck, if you don't mind. But, the old adage, an ounce of prevention is worth a pound of cure. When a pound costs you $20,000 per pound, that says a lot. And so preventive medicine, especially standardized aggressive preventive medicine using things like Lean Six Sigma, help us not only to reduce risk for the patient, but are fiscally responsible for NASA as well. We use a lot of technology. Now, most people, unfortunately, when they talk about things that come from NASA, they think about hardware, machines, vents, Velcro, Tang. Unfortunately, a lot of the things that actually cascade down into medical practice are thought processes and how we view preventive medicine. But this is one example of some things that will cascade down into the medical care of individuals in a hospital. You know, on the spacecraft, you can't have a fire risk, so we can't have O2 going greater than 28%. So if I ventilate somebody, if I were to intubate somebody and ventilate them, unfortunately a large portion of that oxygen goes into the cabin atmosphere goes up in O2, I've increased the fire risk. One of the things we looked at was a closed circuit ventilator with an O2 concentrator. Literally it takes the oxygen out of the atmosphere, concentrates it, gives it to the patient, keeps it in a closed circuit, doesn't raise the fire O2 limit, and at the same time I don't have these big green tanks any longer needed to carry oxygen. We tested that on about 20 patients at University of Cincinnati to get it FDA approved. We also wrote a computer algorithm that weaned the patient on the vent instead of a respiratory therapist with a clipboard coming around about every hour. What we found was we used dramatically less oxygen doing that. And that cascades to us in the Constellation program because I don't have to carry very heavy oxygen to the poles. Saved us in orders of magnitude millions of dollars because we didn't have to keep that requirement in there for the Constellation program. Some things look futuristic. You know, having that C-pod that's on the far left is about the size of my BlackBerry. When I flew on Life Flight as the chief of Life Flight, I had a Pro Pack that was about 10 pounds that did the vital signs, the blood pressure, the heart rate, all of those things. It's now the size of a BlackBerry. And that BlackBerry has a Bluetooth that transmits up into the helmet what those vital signs and EKG, et cetera, are, and can then transmit it back to Houston. That's not futuristic. We've already done that. We proved that on Devon Island, and that was one of our projects on Devon. So, unfortunately, some of those things take about 12 years before they cascade into medical practice. But those things will eventually cascade into everyday medical practice. So where do we start planning from the exploration side on the medical side? You know, first you have to ask yourself, what is the risk? What are the medical diagnoses unique to spaceflight and the astronaut population? Then what's the mitigation strategy? Now, it might be preventive medicine, like I showed. That's 90% of the time. But what about prophylactic surgery? You know, people say, well, are you going to be able to take somebody's gallbladder out on the moon or Mars? Well, I could, but why would I want to? You know, are we going to do that before they go? Well, there'll be genetic screening. You know, where you do genetic screening to see is a BRCA1 or BRCA2 gene there? Do we need to do something to eliminate or screen out medical disease before it occurs? Well, you fly a physician. Right now we fly CMOs or crew medical officers. But will a physician add to that complement? Death. That's something NASA hasn't had to deal with. But as you get further and further from Mother Earth, the inevitability or the possibility of death becomes more increasingly possible. Risk definition, this is how NASA looks at risk, essentially severity times probability. The problem in medicine is we like to fly all sorts of stuff. We want to fly the ICU, we want to fly the CT scanner, we want to fly the surgical suite to decrease our risk. Although those things do decrease your risk, there's those 6 tenets that we talked about earlier that make it just about impossible to do those things. So you need to reach a balance and a midpoint as to what are you going to fly and what are you going to prevent. There's going to be unique aspects of Moon and Mars missions, distance, obviously, in situ production of consumables, relative autonomy, communication, power production, but most importantly, the reversal of the life-limb mission paradigm. Now, what does that mean? Well, I'll give you an example. If I have an astronaut right now that gets a corneal abrasion on orbit on ISS, and it gets infected, and we give eye drops or the salve, and it just doesn't heal, to where now we're getting corneal scarring, things are getting worse, we're not going to make that astronaut sacrifice their eye for the space program. I'm not going to have them with their nose pressed against the glass looking at the Levin Eye Institute every 22 minutes thinking, wow, I really wish I could be there. We'll bring that person down. We'll get care. But you got a corneal abrasion on Mars. Guess what? We can't abandon the mission because of that. You might be one-eyed Jack coming back, but That's the reality of an exploration mission. It's the reversal of the life-limb mission paradigm. The mission now is more important than the life or limb. And that's the first time that we have that is in the exploration missions, the further we get from Earth. Modularity, kind of the building blocks that we have for how we're going to bring all of that equipment to bear. We're not going to fly the same equipment on every mission. We're going to build things modularly to increase our capabilities. From a physician standpoint, does the training exist right now to fly a physician? And let me give you some examples. And Dave could probably say this better than I could. When you become an astronaut, you work on astronaut stuff. You don't necessarily see patients and keep your clinical skills up. But for an exploration mission, you're going to have to. The other problem is the residency that you need doesn't exist any longer. Back in the 60s and 70s, your family doctor, if he became a family practitioner, learned to birth babies, assisted on C-sections, learned to be second assist or first assist in surgery, learned emergency medicine, learned family practice. Now, partly because of being in a litigious society and partly because of specialization, it's hard to find anybody that knows a little bit about all of those things. Now, of course, I don't think we're going to have to worry about C-sections and such on exploration missions. Let me knock on wood there. But being an all-round family practitioner, emergency medicine physician, general surgeon, maybe. And so does the flying the physician also reduce the overall risk? Then where do you stop? Common things occur commonly. Do you start planning for zebras? Probably not. You certainly want to cover spaceflight unique medical maladies. There are residuals that were not screened out. And then using evidence-based medicine and expert opinion to cone down the number of maladies to protect for. Now, levels of care. I always have to have a discussion about levels of care with program managers, whether they be shuttle, ISS, or Constellation. There's a difference between the standard of care and a level of care. The standard of care, you hope the ambulance on the east side and the ambulance on the west side provide the same standard of care. But you're not going to have your appendix out at the firehouse. That's a different level of care. Now, folks will say, well, do you want to take out somebody's gallbladder on the moon or Mars? Well, I might be able to. I might be able to do that with robotic surgery. But most of us as physicians have done those ICU rotations where somebody nicked the cystic duct, or somebody tied off the wrong artery, or something occurred that went awry. And this patient in the ICU was one of those examples. This was a simple gallbladder surgery that went awry. And the patient's now in ARDS with multiple chest tubes and an open belly and septic. Those are the things that worry me for a Constellation mission if we start planning for doing those procedures on the moon or Mars. I prefer not to do that. Autonomous, the crews are going to have to be autonomous. Right now, the flight directors plan just about every minute of their day, but they're going to have to be autonomous. We're going to have 20-minute one-way communication. I can't have the surgeon on console, and if somebody's in VFib, say, clear. Yeah. 40 minutes later, that shock will be done, and it's not going to be very fruitful. You can't abort to definitive care. We're not going to be able to come home for definitive care. You must have the proper training and care for the majority of the medical issues with you. And a consultant's going to be available, but not for emergent care. You're going to have to look at things from multiple perspectives, like this photo from Mars, looking at the Earth and the Moon. You're going to have to leverage experience, both our past experiences as well as analogs. And you're going to have to do pretty good forecasting, looking at previous experience, your CONOPS. We use a Delphi technique to try to get expert opinion to figure out what we're going to need for the Moon or Mars. You have to look at your fault tolerance, your probability, and your risk mitigation. This is an artist's conception of what we're going to do on Mars. I certainly hope that's not what we're going to do on Mars. Because if we're having some guy rappel and he's held to the rock by 2 prongs on a little rope, we got issues. This is for Dr. Bevan, my NASA psychiatrist. I always throw that slide in there. I'll let you read that for a second. But obviously exploration is going to have unique psychological and psychiatric issues as well. Things that we really don't have to worry about for short duration missions. But keeping the big picture in mind, regardless of what your political thoughts are as to whether or not we should go back to the moon or go direct to Mars, etc., strictly speaking from a physiologic standpoint, it takes us 6 months to get to Mars, and We have an analog for that. ISS right now is microgravity for 6 months. We could do long duration lunar missions, which give us 1/6 G, and any countermeasure that works in 1/6 G is going to work in 1/3 G. And so from a physiologic standpoint, regardless of what your politics or your beliefs are, physiologically, we have a good model for how to get to Mars. We'll see if we have the finances or the politics will allow us to do that. But from a physiologic standpoint, we have the ability to test those things. And that's it. Any questions? Has anybody seen the new Star Trek movie? Right. Well, you guys did a good job. I'm clapping for you. You guys did a good job staying awake after a meal. I'm pretty impressed. And I won't stand between you and the bar. Any questions? Excellent. Everybody wants to get to the bar. Yes, sir.
Just one question, and that's, I was happy to see you using electronic medical records, but have you been able to break the code yet in getting astronauts to trust you to access the electronic medical records from their civilian physicians so that you really do have an accurate record of...
Well, that's a tough one because we use so many different consultants. Mayo Clinic and Cleveland Clinic allow us to access their records easily. It has more to do with the hospital sites than it does our patients. If we go to Methodist downtown, we don't have access to those folks. And so, but I've got access to the Mayo Clinic and Cleveland Clinic, but I can't get into my own backyard. So we're trying to get there. What's unique, and of course the new presidential administration is working on that, is there's so many different EMRs with different languages that don't speak to each other that it's difficult for medicine as a whole. If you're seen at Clear Lake Regional and then go to St. John's, the two don't speak to each other electronically. So we'll see how we get there. But at least from NASA's standpoint, all of the medical care or clinical care that our folks are going to receive, regardless of where they're at, whether that's going to be Star City, White Sands, JSC, et cetera, or KSC, we'll be able to get to that electronic medical record. Now that helps a great deal for the research folks as well, because there's 50% of our stuff is being lost before, because it was not being captured in electronic medical record. So we didn't really know how many incidences of X we had. The other difficulty that we have, Charlie, is because of medical confidentiality, I'm the only group at NASA that can't boast on my successes. I can't go to the astronaut corps and say, look at X, John, who just had AFib that we took and did an ablation for his AFib, and we've got him back to flight. In fact, nobody in the Corps knows that that guy had AFib. They know that the docs squished him for a couple of weeks, but they don't know why. The folks that we've had with pituitary adenomas, 2 great saves that wouldn't have been picked up otherwise, multiple prostate cancers, things that, quite frankly, were huge in their pickups and alleviating mortality and morbidity, but we can't market them. And so the astronaut corps themselves probably have no idea all of the things that we've taken care of. And that, in essence, to some respect, does not allow us to that warmer relationship with the astronaut corps. Yes, ma'am.
I know everybody wants to get to the bar, but anyway, you mentioned the psychiatric or psychological support, and I know you've done a lot. Can you just expand a little bit on that?
Well, there are things that you don't expect with the psychological support. And I'll give you an example. There are some things that you think are a pro, and sometimes they're a pro, and sometimes they bite you when you least expect it. The internet phone, IP phone. Crews love the IP phone because they get to touch base with home. They get to talk to home. They know what's going on with home. That's a plus sometimes, and sometimes it can be a negative. Because after your long 7.5 hours working on everything, and then you call home and it's, Johnny got a D in math again. I thought you talked to him. You talked to him on the phone. And where did you put that plumber's bill? I thought you paid that. I need you to call these guys. And so there's a pro and a con. There's the being attached to home, and then there's being attached to home. And so we're finding out, but that was good, actually, for our standpoint, to learn that psychological support has a double-edged sword sometimes. And certainly more and more for constellation missions, group dynamics will come into play, and whether or not, I can tolerate my kids and my wife in the car for a week driving out west, but if it were 18 months on a particular mission, wow. I think my wife would be in jail for murder. She'd probably kill me after about 3 weeks. And so finding those things, that compatibility, and it plays into selection. I mean, we wanted type A, gun-ho, maybe a little ounce of narcissism folks for short duration shuttle missions. That doesn't necessarily play very well for long duration ISS or exploration missions. And so the dynamics of folks that will play together, live together, and do missions together changes a little bit. And will require a lot more research and data and input. Does that help? Okay, Mike stopped talking too. So if yes, sir.
The training of the astronauts and psychologically getting them prepared for the flights. What about the families? Do you do that to the families too to avoid some of the things you were just talking about?
We do, but probably not enough. Especially as we get into constellation missions, we're going to need to do more. And this is my opinion, not NASA's opinion necessarily. When it was only a military paradigm back in the Apollo and the early days, those folks were also married to military wives who were used to deployments, used to moving every 2 years, used to the hardship of military life. And it's a little bit different now with folks that are not necessarily military coming into NASA. And all of a sudden their spouse is spending 6 months in Russia and what do you mean they're not going to pay for this anymore, and what do you mean this is happening, and what do you mean about that? So we probably need to do more to help ready those families, not only for long duration missions, but also in the pre-mission phase, the training and the impacts that it takes on the family. Because it is hard on the families going back and forth to Russia and doing training and doing all the things that they do. Yeah. Yes, sir. You want to do one more, and then we'll...
So I understand the critical and excellent work that you do on the screening. What we find, though, in a lot of experiments now, and this is true, so true for medicine in general, that it's led to this movement towards personalized medicine, is identifying differential vulnerabilities. So even in a cohort of otherwise top-notch people, some are going to be more vulnerable to certain things than others. We'd love to be able to know what those are so we can mitigate, prevent, target countermeasures. Would you comment on that as an approach?
Yeah, and actually, thanks, David. That's actually a very good lead-in. Some of the changes that we're making, I'll take cardiovascular as an example. Right now in the U.S., people gear their statins towards a particular number. If your LDL cholesterol is greater than 100, you're going to be placed on a statin, unless maybe your mother or father had an MI, then we'll shoot for a lower number. One of the things that we're trying to do, and we've been working with our cardiology folks throughout the country, some of the experts throughout the country, in the next month and a half, we're going to start CIMT ultrasounds, carotid intramedial thickness ultrasounds, in our clinic, with the goal of not aiming our statin care at a number, but aiming it at soft plaque. Because some folks lay down soft plaque at an LDL of 110. Folks who are from Milano, Italy, don't lay it down until they've got an LDL of 130. Other folks lay down soft plaque at 100. Still more folks have a genetic predisposition to lay down soft plaque at an LDL of 70. And so rather than picking an arbitrary number, we're now going to focus it and aim it at what number those folks are laying down soft plaque. So if we see an increase in soft plaque, then we're going to manage our statins based on what we see on those CIMTs, not necessarily based on an arbitrary number that we pluck out. So that was a good example. And then we're going to try to carry those in our clinical practice guidelines to make those tailored towards each patient and other venues, whether beyond cardiovascular. So that eventually, that was a good example of how everyone focuses on Velcro and Tang and other things that come with the space program. That's a thought process on preventive medicine that will eventually cascade into practice that NASA's ahead of the curve on. But how do you put that down so that folks know that came from the space program? Okay. Well, thanks, folks. Thanks for having me.